Coming up on Mayo Clinic Q&A.
Lymphoma is not one disease that we can put a finger on in terms of a causative or one single cause. Aging increases the risk of lymphoma, and that's more likely because throughout our life, we accumulate genetic errors in our DNA. These mutations, if happening in specific genes of our body, can make us prone for the development of lymphomas.
Lymphoma is a cancer of the lymphatic system, which is part of the body's germ-fighting network. There are many types of lymphoma, and knowing exactly which type you have is important to developing an effective treatment plan.
It is a disease that has many different faces. That's why it's really important to understand from the beginning, if you have an accurate diagnosis, there are many of these diseases that are curable, meaning that we are treating to get rid of the lymphoma and hope it will never come back again.
Welcome everyone to Mayo Clinic Q&A. I'm Dr. Helena Gazelka. Today we're going to talk about a type of cancer called lymphoma. Lymphoma is a cancer of the lymphatic system, which is part of the body's germ-fighting network. The lymphatic system includes the lymph nodes or glands, the spleen, the thymus gland, and the bone marrow. While many types of lymphoma exist, the main subtypes are Hodgkin's lymphoma and non-Hodgkin's lymphoma. What treatment is best for a patient depends upon the lymphoma type and its severity. Joining us to discuss the various types of lymphoma and how they are treated is Mayo Clinic hematologist, Dr. Jose Villasboas. Thanks for being here today, JC.
Nice, good morning, and thanks for having me here, Helena.
Well, it's always fun to learn about something new. All of our listeners know that I like to learn something new every day, so I'm excited that we can have a talk about lymphomas today. Tell me a little bit about the signs and symptoms of lymphoma.
Absolutely. So it is really unfair to put all these diseases that lymphoma actually are in one category. Just like cancer, it's hard to put everything under one umbrella. And when I talk to my patients about lymphoma, I try to really divide into the main groups and how they present and how patients find them can be fairly different. For example, there are very aggressive types of lymphoma, and those typically will present with symptoms. And those are the types that I usually tell the patients, those are the lymphomas that find you, and as opposed to those that you find by accident. So the aggressive lymphomas can present, yes, and can present with high fevers or cyclic fevers. It can present with night sweats or sweats in general. Normally not a subtle type of sweat. I'm talking about drenching night sweats. When I ask my patients, I ask them, have you ever seen if you have to change your sheets in the morning, you have to change your pillowcase, you change your pajamas when you wake up because you're drenched in sweat? That's a type of night sweat that are really associated with lymphoma, not feeling just a little bit hot at night. And then you can also have unintentional weight loss. So you're not trying to diet or exercise, but you're losing pounds. Or in some cases, patients are exercising, but they're losing more pounds than they expected based on their previous experience. So those are what we call constitutional symptoms that can be present in lymphomas. And because lymphomas can happen in virtually any part of the body, you can have symptoms associated with the presence of the lymphoma or a growing mass, let's say in your abdomen or in your chest, that can lead to abdominal pain, discomfort, shortness of breath, or chest pain. So those are the signs or symptoms that can be present in patients with aggressive lymphomas, those that are rapidly growing inside the body. And that's quite different from indolent or slow growing lymphomas. And those are the ones that are more likely to be found by accident. So a patient goes to the emergency room with a kidney stone, someone gets a CAT scan and they see an enlarged lymph node that it may have been sitting there for years. And someone eventually gets a biopsy and we find an indolent slow growing lymphoma. And those are typically not presenting with many symptoms. If anything, they can present with an enlargement of a lymph node. Those are the typical kind of two groups of presentations.
JC, what causes lymphoma and who's at risk for developing it?
So the main risk for developing lymphoma is actually aging itself. So we, unlike other cancers, and for example, I try to explain that we know the clear association between smoking and development of lung cancer, or the presence of the human papillomavirus and the development of cervical cancer in women. There's not such a strong link in lymphoma that you can point to one particular cause that leads to lymphoma, with very rare exceptions. And the exceptions are, for example, the presence of the H. pylori infection in the stomach can lead to a very specific type of lymphoma in the stomach that sometimes doesn't need any treatment other than the eradication of the bacteria itself. But aside from these, unique cases, lymphoma is not one disease that we can put a finger on in terms of a causative or, a one single cause. But there are themes. So we know that, just like I said, aging increases the risk of lymphoma, and that's more likely because throughout our life, we accumulate genetic errors in our DNA. So our DNA changes and accumulates mutations, and these mutations, if happening in specific, genes of our body, can lead to, can make us prone for the development of lymphomas. The other theme is immunity. We know that immunity is tightly related to lymphoma, and we know that because patients who are under treatment for diseases that require them to decrease their immunity, for example, transplant patients or patients with autoimmune diseases, those treatments that are used for those patients can increase your risk of lymphoma as well. And then finally, just general risk factors that have been associated, and sometimes those take a lot of attention from the media. We know the associations between Agent Orange and lymphoma, or more recently, some pesticides and lymphoma. Those are associations so far. We can't really say that those are causations. They are not necessarily one, direct link between you have exposure and you have lymphoma. So those are the main risk factors. There are also some familial syndromes, extremely rare, that can predispose one to developing lymphoma later in life.
JC, I have a question about what you said about lymphomas being more common with age. In the intro, I had mentioned that there's Hodgkin's lymphoma and non-Hodgkin's lymphoma. And I've been aware of younger individuals having Hodgkin's disease. Is that true, or is that just my perception?
That's very correct. Actually, Hodgkin's lymphoma has two peaks. So it peaks at the college age, between 20 and 35. And that's where most people will hear about patients with Hodgkin's lymphoma, because that's quite a dramatic event in a young adult's life. And then there's a second peak, and that second peak is at age 65 to 75. And that's, in between these two groups, there's really a valley, and there's very, little incidence in that kind of middle age. And that's the opposite for non-Hodgkin lymphoma. You have a growing peak that starts in adult life and keeps just increasing as the person ages.
JC, if an individual or if their physician is concerned that they might have a lymphoma, what is done next to diagnose it?
Yes, so let's say a patient presents with enlarged lymph node under the arm or on their neck. The very next step is to just get a basic evaluation, just make sure that we have a blood count, make sure there is nothing obvious circulating in the blood, which is rare for most lymphomas. Normally, a blood count is normal for patients with lymphoma. And then the first and foremost is to get adequate tissue diagnosis, Helena. And that's because I stress adequate, because many times I see patients who come to me after having been through 2 or 3 needle biopsies in which they took a very small piece, or didn't even take a piece, they just aspirated with a needle. And that's not usually sufficient for a diagnosis of lymphoma. And that's because to diagnose lymphoma and to make sure that we have the accurate subtype of lymphoma, we normally need an adequate amount of tissue to look at the architecture of the tissue. Where are the cells that look malignant, the cancer cells, and how are they in context with the other cells of their surrounding? That's because that information is crucial to actually accurately diagnose the patient. So adequate tissue biopsy, and many times a small incision in which we actually take a surgical piece of the tissue, is the best way to actually diagnose lymphoma.
So what do you do after you have a diagnosis? How is lymphoma treated?
So after the immediate diagnosis, we will proceed with staging like most cancers. And in this case, we will try to find out whether the lymphoma is really localized to that one lymph node chain or lymph node area, or has it spread to more than one other lymph nodes and to other tissues that are prone to have lymphoma, such as spleen and the bone marrow. So normally there will be some sort of scan done. Normally in lymphomas, we favor a scan such as the PET-CT scan, which gives you both anatomic as well as functional information. So, and that's the initial test that we will do for most lymphomas. And in some cases, we need also to sample the bone marrow of the patient. So we're using a bone marrow biopsy to find out whether the lymphoma is also in the bone marrow. And that will give us the ability to stage between stages 1 through 4, and finally, come up with a treatment plan for lymphoma. And lymphoma is generally treated with with a combination of different treatment options, which are, definitely we use chemotherapy, but more and more we are combining chemotherapy with additional tools such as radiation. And radiation and chemotherapy, when we use them together, we call that combined modality treatment. And in lymphoma, at least for the B-cell lymphomas, which are the most common type, we also use immunotherapy to treat patients, and that is using drugs that will not necessarily kill the lymphoma directly, but will actually use the patient's own immune system to help get rid of the lymphoma. And those are used typically in combination with chemo. So we'd often say that we're going to give the patient chemoimmunotherapy because we're combining both agents that use the immune system as regular chemotherapy. And then obviously in some cases, those that are aggressive or relapsing, so the cancer returns after the initial treatment, we need to resort to some specialized treatments such as stem cell transplantation. And more recently, we are using cellular therapy, such as this new treatment called CAR T cell therapy. It stands for chimeric antigen receptor T cell therapy, which is a way to use the patient's own immune cells to get rid of the lymphoma. It's quite effective.
It sounds very technical to me. Tell me, JC, we haven't talked much about children, but is the treatment for lymphomas in children different from that in adults?
In some ways, yes. For the most part, we have the same tools, and we use also chemotherapy, immunotherapy, radiation, and sometimes transplant to treat children too. The main difference is that almost all lymphomas that present in children, they are treated with a curative intent, so with the goal of getting rid of the lymphoma. And many times that treatment is quite aggressive because we want to make sure that that child has a full life. And in some cases in adults, we have slow growing types of lymphoma in which the goal is not to get rid of the lymphoma, because many times that's not possible. The goal is to control it. And therefore we have to choose our tools so that we really balance the risks and benefits of treatment. And in terms of children, we almost always go with an aggressive therapy to really get rid of that cancer, but at the same time, making sure that we minimize any long-term side effects of the treatment as those children grow.
So we were talking earlier, you mentioned cervical cancer, I think. And so in many types of cancer, cervical cancer being one, breast cancer, colon cancer, there are screening tests that can be performed with someone's annual exam or otherwise. Are there screening tests for lymphoma?
There are not. There are currently no way to effectively identify lymphoma for patients who are concerned about it. There are definitely studies, looking into that very question, but at this time, there's not a standardized way to identify at an early stage a patient with lymphoma.
I'm going to ask you this next question, but you've already told me that aging is one of the highest risk factors for the development of lymphoma, and none of us can stop the fact that we're aging. But is there anything that can be done to prevent lymphomas?
Great question. So in terms of one singular intervention, so we know that if you stop smoking, you decrease the risk of lung cancer, right? If you screen for the HPV virus and treat it, you decrease the risk of cervical cancer. There's not one single thing that you can do to prevent lymphoma. Obviously, like I said, the immunity is important, and that's part of the aging process. Is also something called, aging of the immune system or immunosenescence. So as strong as you can keep your immune system, at least in theory, you're better off in trying to prevent cancer in general, lymphoma included. So although we don't have one particular thing that I can tell patients to do, we do have some information that at least hints towards very potential interventions that are under investigation. And I mentioned that because we know, through a study done here at the Mayo Clinic in collaboration with the University of Iowa, that patients after a diagnosis of lymphoma who exercise actually do better compared to those that don't. We also know that patients at the time of diagnosis, if you compare their exercise activity with those of the people of the same age, and if they have an exercise level that is above average, their outcomes in the treatment of lymphoma is better. And that to me tells me that there is definitely a link between healthy lifestyle, exercise included, and either the prevention or the treatment of lymphoma. So although we don't have one study to absolutely prove that by exercising you would decrease your chance of lymphoma, it's very reasonable to believe that these interventions, which are sometimes common sense, but in many cases very important, could lead to a decrease later in life in the development of cancer and lymphoma, perhaps also included.
I feel like what seems that it may be common sense and very easy to implement is not necessarily so. I think almost everyone that I interview on this program says that a good healthy lifestyle, including exercise and a good diet, are beneficial for almost all areas of our health.
Absolutely. And one thing that I tell my patients about exercise is it is, again, everyone knows that exercise is good for you, but most people think that the way it, helps your life is just by improving cardiovascular health, which is very true. We know it decreases your chance of stroke and, myocardial infarction, heart attacks. But in the case of this study, we actually showed that the chance of dying from lymphoma itself is decreased when you exercise compared to when you don't. So it's not because people are living longer because they have less heart attacks and therefore they did better. Well, that's true as well. But what we found is a direct link between exercise and lymphoma-specific mortality, or the chance of dying from lymphoma itself. And although studies are still underway to explore this link, I have to believe that the link is mediated by the immune system. So those patients who are exercising, they have a healthier immune system and therefore allows them to keep the lymphoma under control and protect them from having to come back later.
That's very interesting. What are the survival rates like for lymphoma?
Yeah, so that's a very hard question to answer. And that's because although we say you have lymphoma, inside that umbrella, there are over 100 different types that are now recognized by the World Health Association. So it's really unfair to give you a number that represents all lymphoma groups because they best, widely. But I'll give you some idea of at least dividing between, the main types. Like I said, the aggressive lymphomas and the slow-growing lymphomas. So in terms of the aggressive lymphomas, and that includes, things like Hodgkin's lymphoma is considered an aggressive lymphoma, and diffuse large B-cell lymphoma, which is the most common type of lymphoma in the United States. The survival rates for Hodgkin lymphoma, when you look, according to the stage, will vary anywhere from, 70 to 90%. For diffuse large B-cell lymphoma, that number usually sits between 60 and 70%, the 5-year survival rate. Okay. Because that's where most studies will measure to. When we look at indolent lymphomas, and those are the ones that are, again, incidentally found, those that are found by accident, not the type that finds the patient, right? So those grow very slowly. So the 5-year survival rate for those indolent lymphomas, slow-growing type, are sitting around 90%. That's because many patients will actually have that lymphoma for many years, and we don't even need to treat sometimes. We just observe and wait for a true indication for treatment.
JC, when you were talking earlier about all of the modalities that can be used to treat the different types of lymphoma, and now that you've told me there are over 100 different types, how can an individual be certain that they are receiving the best care that they can receive if they receive a diagnosis of lymphoma?
Of course. The main problem with lymphoma is accurate diagnosis. It is, first of all, it is a rare cancer in proportion to the other cancers. There are over 250,000 cases of breast cancer in the United States per year, and there are about 70,000 cases of lymphoma per year. So put this in perspective, most cancer doctors would not see many lymphoma patients in any given month or in a given year. And in comparison, having so many different types inside one simple, label lymphoma, really means that you have to, have your diagnosis verified by a center with high volume. So someone who actually sees this type of disease, day in and day out. So one is a diagnosis, and once the diagnosis is done, accurate staging is really necessary for, for designing the treatment plan, which has to be individualized. You have to take into consideration the obvious fact of what type of lymphoma this is, how does it normally behaves, but at the same time, you have to take into consideration the characteristics of the patient. What is the age of this patient? What other risk factors they have? What other medical problems do they have? And then decide what's the right treatment for them. So it is really important to seek, attention and care, at least for one-time opinion in a center with a high volume of patients with lymphoma.
And JC, is it something that patients can ask for if they want their pathology to be sent to another center to be examined?
Very much so. Mayo Clinic, sees a lot of lymphoma patients, and our hematopathologists, those are the, pathologist specialists who really are the experts in diagnosing lymphoma. They see samples from patients coming from all over the world. And that's something that they can actually have, requests from their local doctor to be pursued.
Tell me a little about ongoing clinical trials at Mayo Clinic for lymphoma.
Absolutely. So the lymphoma group at Mayo Clinic is very active in terms of experimental research. At the present, I just took a look before joining our call, Alina. We have in our catalog over 106 open studies for lymphoma at the Mayo Network, meaning either here in Minnesota, Florida, and Arizona. Some of those studies are interventional studies, meaning we're giving some sort of therapy. And there's about 50 of those currently open as of today. And some of those are observational studies in which we're looking into risk factors or prognosis of patients. And these will include trials that are testing a variety of different interventions. So we have trials that are testing, drugs such as different types of, agents that kill the cancer cell directly. We have targeted therapy drugs. Those are usually drugs that are acting on a specific gene or a specific metabolic pathway or a specific part of the cell, and trying to reverse that problem to help cure the cancer. We also have immunotherapy trials. So those are agents that are, helping the patient's immune system get rid of the lymphoma. And we also have cellular therapy trials, such as the CAR T cell trials, in which we're genetically modifying the patient's immune system to then fight best against the lymphoma themselves. And there are obviously combinations of those in those trials as well.
Sounds like an exciting area of research.
Very much so. Many of my other oncology colleagues are envy of lymphoma, oncologists, because we seem to have all the, the tools coming to lymphoma all at one time. And obviously the field is evolving in cancer care in general, but at lymphoma we have made great progress in the last 5-10 years.
JC, one of the issues that we've been concerned about at Mayo Clinic, both in relation to medical care at baseline and also to clinical trials, are that there are sometimes disparities. Some individuals have better access to either clinical trials or to treatment than others might. Are there disparities related to lymphoma research and treatment?
Yes, there are disparities in the United States in terms of lymphoma access to care and also lymphoma outcomes, meaning the chance that someone will be successful in their lymphoma treatment. So if you look at the numbers as it currently stands, Helena, the incidence or the likelihood that one given person will have a diagnosis of lymphoma is still higher in white patients compared to non-white, African American, Hispanic population. But if you look at the outcome, if you try to match by the risk factors, age, stage, and type, the outcomes in the minority population are disproportionately lower compared to the white population. So there's still a need to understand exactly the link between these two, but there are clear disparities in terms of lymphoma outcomes in this country. Yes. Is
that an area that we're trying to work on at Mayo Clinic?
Absolutely. With the Mayo Clinic Cancer Center, there's a great focus now into understanding and fixing, healthcare disparities in cancer in general, and lymphoma included. There's a great focus for our group.
That's wonderful. I'm happy to hear that. Anything else you'd like us to know about today, JC?
I think that lymphoma is, one of the most interesting cancers in my opinion. I'm very biased, obviously.
I'm glad that you feel that way.
all I do. I really only see lymphoma patients with rare exceptions, and it is a disease that has many different faces. That's why it's really important to understand from the beginning. If you have an accurate diagnosis, there are many of these diseases that are curable, meaning that we are treating to get rid of the lymphoma and hope it will never come back again. And that's a big deal because some cancers, even at advanced, in advanced stages. So if you take a patient with, breast cancer, pancreatic cancer, I think is a better example, who is stage 4, currently that is unfortunately a diagnosis for which we don't have a cure. In lymphoma, I try to stress that to my patient that there is a chance of curing stage 4 lymphoma. And that's why it is important to make sure you have the accurate diagnosis, you have the accurate staging, and that will give you the best chance of having the best outcome.
JC, we keep talking about accurate diagnosis. Do you ever see patients who have had a diagnosis elsewhere, and then you review their pathology or have it reviewed here, or obtain new samples and change the diagnosis?
Absolutely. It's not very frequent, but because we see a lot of patients, we do see that happen in some patients, which we change sometimes from finding what was once called a slow-growing lymphoma, and when we review it, we find it actually to be an aggressive lymphoma, and the treatment will change completely, dramatically, from one type to the other. So yes, that happens.
So a good area to consider a second opinion, I imagine.
Absolutely.
Thanks for being here today, JC.
Thank you for having me here, Halina.
Our thanks to Mayo Clinic hematologist, Dr. Jose Villasboas, for being here today to talk to us all about lymphomas. I hope that you learned something. I know that I did, and we wish each of you a very wonderful day.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then click on Podcasts. Thanks for listening, and be well. We hope you'll offer a review of this and other episodes when the option is available. Comments and questions can also be sent to Mayo Clinic News Network at mayo.edu.